Good evening, everybody. Good evening and welcome. Welcome to all of you. Thank you for joining us this evening. I welcome you to the fall 2018 edition of the Beth Tzedec Tzed Talk, which is a series of medical presentations and health presentations that we've been putting on for the last several months. My name is Eddie Lang. I am the department head for emergency medicine here in Calgary, and also sit as the scientific director of something within Alberta Health Services called the Emergency Strategic Clinical Network. And that network, along with the Cummings School of Medicine, are some of the proud supporters of this event tonight. I'd like to acknowledge Dr. Hatfield, who is the Associate Dean for Special Projects and Community Engagement, who's been a huge supporter of this series and has really helped us enormously with communication. So thank you. Before we get to our talk tonight, our presentations, and introduce our speakers, I'd like to call up Rabbi Osachi, who would like to say a few words up at the podium on this whole series and why it's so important that we're all here.
Welcome, everyone. Nice to see so many people interested and here to learn more about this very important topic. I just want to convey my thanks again to the Cummings School of Medicine as well for their continuing support of our series here. It's been quite informative and educational. So this evening, the point of this program and the point of it being here at the synagogue is that we really do believe that it's our responsibility to bring programs and information to the community about pertinent and relevant issues, especially medical issues. And so the panel this evening couldn't be more timely. As all of you know, at 12:01, we become a country that will have legally available recreational marijuana. Something that, as a personal aside, I never thought as a 60s Berkeley student would ever happen. But here it is. And I thought when I was a student that, of course, I would be just cheering the day when this would happen. But I find myself not really cheerleading, really just thinking about what this really means, what it means to the community, what it means to our young people. And I think this topic is therefore really relevant. There's a lot of confusion, there's a lot of ambivalence, as well as the predictable celebration that many will exhibit this evening. As a Jew and as a rabbi, I also believe that there's something that religion has to say about this issue. That's not the agenda tonight, so come on Shabbat and I'm going to give my marijuana sermon. Judaism and marijuana. But let me just say that I think as we talk about the medical issues, some of the religious issues do have to, they do have something to say about how we view our bodies, our health, our mental health. They have to do also with whether medical benefits are appropriate to be used. And I think most profoundly, how do we define joy and happiness? And a lot of people will be happy, but will they really be happy? And so I think our tradition speaks to that, as do other traditions as well. And I hope that other religious communities step forward and articulate some of the moral and ethical implications of this change in our society. For me, I'll just say that God plants and gives diversity in creation. So I think everything has a purpose and it has an intentionality to it. Oftentimes that's for us to discover what that might be. But as a result, I think in and of itself, I would say that for me, marijuana isn't inherently bad or good. It really is a reflection of what we make of it, how we use it or not use it, and how we ultimately allow it to shape and form how we become as people of faith and how we create our religious community so that we, in fact, actually achieve what the Torah hopes we will achieve, that's to become a kingdom of priests and a sacred nation. So how do we elevate ourselves, not to use any puns or anything, but how do we uplift ourselves always is the foremost and I think the most poignant concern that we have. And so where does cannabis fit into this? I'll turn it back to Eddie. Thank you.
Thank you, Rabbi. So we've entitled tonight's presentation, Confused About Cannabis. And when we planned this several months ago, we knew that there would be many, many questions out there about what legalization would mean, what the impact would be, and we've purposefully arranged this evening to allow lots of time for you to ask your questions. We have amazing guest speakers with us tonight, and I will introduce them. The first, who will be speaking to us on more of the health policy and the government decisions that have led to legalization. It's my pleasure to introduce to you Professor Fiona Clement. Fiona and I know each other from collaborative work that we've done together at the Cummings School of Medicine. I'm a huge fan of the work that she does. She's an expert in health policy, health technology assessment, and in health economics, and has been a great help to us. And I'll also encourage her to say a little bit more about herself as she begins her presentation in just a minute or so. Our other guest speaker, we wanted to bring in more of the clinical side of things, and that's where Dr. Paul Arnold will take up the podium. And he is a child psychiatrist, a researcher, renowned researcher at the Cummings School of Medicine, does work in the developing brain, and will speak to us some of those issues. You may have noticed that we had hoped for 3 presenters tonight. Professor Rebecca Saw-Haynes is a well-known Cummings School of Medicine researcher as well, with expertise in cannabis, who had a family emergency, unfortunately, and couldn't make that. But we're all quite familiar with her messages, and during the question and answer period, I think we'll be able to relay to you what she might have thought about this. I as well, being an emergency physician, am happy to take questions as well. I won't be doing a presentation, but if there are questions about what might come to the hospital, what we might see as some of the adult toxic effects of cannabis use, I'd be happy to address that, as well as share some of what I've learned from colleagues in the U.S., especially in Colorado, who have had the same experience. So prepare your questions. We'll have lots of time. We want this to be a very comfortable environment. There are no bad questions. If you're thinking about it, then others are too, and that's even despite the flood of media attention that this subject has reached. So if you want to have some additional clarity, we'll do our best to answer this question, your questions. So without any further delay, I would welcome Professor Clement to the podium.
Thank you, Eddie, for that introduction. The only thing I'll add to what Eddie said is that it's been my privilege to work on this file. My role in it has been advising the government on what the policy looks like. So it should come as no surprise to you that I think we did a fantastic job. But what I'm going to be talking to you about today is kind of how we developed the policies that are rolling out tomorrow, and some of the things that really surprised me throughout the process of kind of gathering the evidence that was used to support the policies that are being current. So tomorrow, we will move from the relative left side of this chart, where we have cannabis as a criminalized substance, meaning that production, sales, and use are currently criminal activities in Canada. As of 1201, we will move to the far left side, legalized, down there, where all 3 of those activities, within the bounds set out by the government, will be legal, meaning there will be no criminal penalties for doing any of those activities. We will be the second country to do so, the first being Uruguay. So we really don't have a lot of solid examples to look to and learn from here There are several states that have legalized, but that is within the context of cannabis still being illegal federally. So again, we'll be the 10th jurisdiction, second nation, and we're really trailblazing here, which is kind of exciting. So just kind of as a teaser, who in the room supports cannabis legalization? Put your hands up. All right. So as part of the activities that we did to support the government, we kind of took the pulse of the nation. So we did a survey of Canadians, and this is a little bit old. This is from June 2017. But what you see here is that across the 4 major provinces, so Alberta, British Columbia, Ontario, and Quebec, we analyzed the data by age group, sex, income bracket, and education level. And really my takeaway from this graph is that there is no subgroup across these 4 provinces that have less than 50% support for legalization in Canada. So this does have the majority support of Canadians, which is, I think, probably what's carried the Liberal government forward on this particular election promise. How does policy like this get made? It's a little bit like making sausage is the joke in my field. It's not pretty, but the end tastes good. So you start often with evidence, which is the role that I played in this particular file. So the government said, go out and find every single piece of information that we know as a scientific community and bring it back to a table for us to develop some ideas and take out for broad consultation among Albertans. So they did that. They actually consulted with Albertans twice, and over 60,000 Albertans provided input through roundtables, website consultations, closed-door roundtables, town halls, those kinds of activities. They then kind of brought all that information back into the government, tabled a framework, and did some more closed-door consultation with key stakeholders. That engagement process was very, very broad, including fire, police, and chiefs, municipalities, the liquor boards, the restaurateurs union, all sorts of people were around the table for those closed-door conversations. And that eventually led up to the legislation that was tabled and passed and will be enacted tomorrow. And just a reminder, variations of that process happened federally as well as in each province across the country. So that kind of gives you an idea of the scope of policy machinery that has been consumed by this file over the last 18 months. So who is responsible for what? And you can see that first column is the federal responsibilities, then the provincial responsibilities, and finally the municipal responsibilities. So there is something here for all jurisdictions and all levels of government, which is not that common in a policy file. Often there are decisions that rest solely at the federal level or solely at the provincial level, but to have kind of alignment across all 3 levels of government is rare and required a level of coordination that I think took a lot of patience from many people. So out of all of that, what are the provincial priorities that have emerged here in Alberta? And I'll remind you that this is the Alberta picture I'm sharing with you. It does vary province by province and quite dramatically on certain issues. But our 4 provincial priorities are really to keep cannabis out of the hands of children and youth, to protect public health, to promote safety on roads, in workplaces, and in public spaces, and finally to limit the illegal market. What does the policy end up looking like then? And this is an infographic right from the government. So we have landed on a minimum age of 18. We have strict rules about who can sell what kinds of products where. We have rules about where you can buy cannabis. So the only dealer online will be from the government, for example. There's rules about consuming cannabis. At a provincial level, it can be no more broad than our tobacco legislation. Calgary has chosen to further that, to narrow that even more, and there is no public consumption in Calgary of any kind. You're allowed to grow 4 plants in your own home. They have to be inside. You are not allowed to grow outside. And you can possess 30 grams at any one time on your person. You can have more available to you in your home, but you cannot be carrying more than 30 grams at a time. There are rules that are being developed around drug-impaired driving, impairment in the workplace, and advertising and packaging has very heavy restrictions that mimic similar to the restrictions that you see for tobacco. So with all of that, you can see that the policy touches on a variety of different issues. And I just wanted to turn and share some of my big aha moments with you. When I started on this file, I actually thought we would become the land of the tokers. I was very worried that tomorrow everybody is going to be walking around high and I'm not going to have anybody to give me my coffee with the right amount of cream in it, for goodness sakes. And actually what I learned is that when we looked at the rates of use in Canada already, Statistics Canada has been gathering self-report data on people's substance use, including cannabis use, since the mid-'80s. So we have decades worth of data on people's substance use patterns. Just to orient you to this graph, Canada is the first set of 4 bars, and then we move across the provinces. The first dark blue bar is the 12-month past use, so someone who reported using within the last 12 months in 2008, then 2010, 2013. And then we have the lifetime use rates in 2013, so someone who said they've used at some point in their life. And you can see it's pretty consistent for the people who've used in the last 12 months. We have seen pretty steady rates since 1980, really. And you see it's also around 11, 12%. And so what that tells me is that people are already very effectively sourcing cannabis. 12% of Canadians are already using it. So tomorrow we are legalizing it, and this is a Rebecca quote, we're legalizing it, we are not inventing it. We are already using it pretty heavily in this country. When we look at what happens in other jurisdictions, and we have a very short history here with the first US state legalizing in 2012, so that's 6 years only of data, and we're pretty slow in our lag times, so we only have data for about a year post-legalization. But what you see on this graph is the different states that have legalized, and then the dotted horizontal line is the date of legalization. And you don't see any giant spikes there. So we're not really expecting big increases in use, which if what other places have seen pans out here in Canada. Does anyone have any ideas about the group that has the fastest increasing use? Absolutely, the seniors. Yay!
Look who's here.
Absolutely. So the seniors group is the fastest increasing use group, and they are being heavily targeted by the industry. And one of the things that worries me about this is that if you think back to our priorities, we were focused on youth and children use, which is a very important group. But in the senior citizens, clearly we need to be supporting responsible use for that group. And we have no research and no evidence that targets specifically that group, where you might see many other diseases and health conditions that they're trying to manage, and potentially they're managing those with other prescription drugs. And we know almost nothing about the interactions and how cannabis interplays with that very complex health presentation. So I'm very excited. Last week they announced that there's a group that will be focused on developing seniors' best practices use guidelines for cannabis. So I'm excited to see those come out, and hopefully they come out soon. The other thing that was a little bit surprising to me was the harm profile. So I often joke it's green, so it's kind of like vegetables, right? But going back to our survey of the public, we asked people to tell us if they thought cannabis was more harmful than helpful, more helpful than harmful, if it had no impact, or if they were unsure. And we asked them to tell us that in relation to both physical health and mental health. And the big blue bars for the first kind of set of 2 is the Canadian responses. So you see about 40% of Canadians felt that it was more harmful than helpful to both physical and mental health. What worries me a little bit about this graph is that there's about 12 to 15% of people who feel it has no impact on their physical or mental health. And that group is probably systematically different than the people who recognize there is a balance of harms and medical uses or therapeutic use. So this group, I think we need to figure out who they are and specifically target our messaging to them to help them understand that there's a balancing act that they need to think about when they're choosing to use cannabis, if they do indeed choose to use. When we went to the evidence, we did a very broad, it's called a systematic review, where you go out into the literature and find as much information as you can in a very systematic way. And each of these dots represents another systematic review, so another research team that has gone out and accumulated all the evidence they could find. And we just plotted whether the study concluded that there was a harmful association between cannabis and the particular outcome, whether the evidence was so inconsistent that they could not conclude a relationship, or whether they conclude that there was no relationship between cannabis and the outcome. So the red dots are the harmful ones, the yellow dots are inconclusive, and the green dots are no relationship. And what you see is quite a large list of harms that have been considered in the literature, and the majority of those dots are red. So there is a long list of things that we know have negative associations with cannabis. And so there are definitely risks, and we've documented them in the literature. In particular, I'll draw your attention to the list of mental health illnesses there, and you'll notice most of the dots are red, and Paul will be coming back to that, but also the prenatal exposure. So it is pretty clear in the literature that prenatal exposure is risky and leads to birth weight complications and low birth weights. So that message of, thinking about mom and babe, it's best not to use when you're pregnant, has been very well documented in the literature, and we need to get that out. When we're looking at experiences post-legalization, we know very little about what happens in terms of healthcare utilizations and negative impacts in those contexts. But again, each of these dots represents a study that we found that reported the effects after legalization. And you'll see that all of these reported an increase in the particular outcome. So none of the dots are below zero. There was no decreases in any of these things. And they looked at things like burns from hash oil, emergency visits, ED visits to residents of the state, pediatric ingestion, and then drivers testing positive for THC. So we are expecting to see increases in those things, but also remember that we are already dealing with things like impaired driving, right? With 12% of us using, I'm almost certain that not everybody is choosing not to drive after that. So we already are dealing with these kinds of things on the ground in society. There are many, many, many unknowns, and I think somebody I was speaking to today really summed it up. We're living through a very large experiment, and it is our responsibility as scientists and researchers to kind of learn, document, and share our findings and react to them as we move forward. So really my final thoughts before I pass it over to Paul are that we are living through a very large social change. We need to be learning, nimble, and responsive in our policy environment. And excitingly, here in Calgary, we're very well positioned to lead the country. We have a great nexus of researchers, and I'm excited to see where we go over the next few years. I'm going to turn it over to you, Paul.
Thank you.
Okay. So thanks, everyone, and thank you, Eddie, for inviting us, and thank you, Rabbi, for allowing us to come here and present to you here today. So really enjoying the opportunity. So I'm going to switch over to my presentation. I'm going to offer a different but complementary perspective from Fiona's, and this is really taking the point of view of. So I wear kind of two hats. One is as a researcher. Although my own research is not specifically in the area of cannabis, so I'll kind of give that disclaimer. But kind of that sort of academic research perspective in a more broad sense, but also as a clinician. So as Dr. Lang was mentioning, I'm a child and adolescent psychiatrist, so see children and youth and kind of have that perspective. So I'm going to tend to focus a bit more on the risks. Some of the things will apply, across the lifespan. We're talking about, seniors and how there may be risks there. But, as mentioned, we probably know a bit more about the risks in younger people. And again, that's also kind of where I'm coming from my perspective. We do, although it's not my personal area of research, I'm director of the Matheson Center for Mental Health Research and Education. So we're a center affiliated with the University of Calgary and the Hotchkiss Brain Institute, and a number of our faculty do research in the area of cannabis. So it's certainly an area that we're very excited about, and obviously lots of opportunities to learn about with this great experiment that's happening. But I think I think we will learn and a lot more about the impact of cannabis. So this is just kind of disclosures. None of these actually relate to cannabis, but just sort of obligatory disclosure because I'm going to be discussing research that is largely publicly funded. So I'm really going to kind of touch on 3 issues that I think are important from a psychiatric perspective, and I think will be relevant to all of you. So one is this issue of how does cannabis affect brain development, and particularly adolescent brain development? Who is at risk of developing mental health disorders from cannabis? So who's likely to come into my office or the office of other psychiatrists as potentially as a result of cannabis? And I'll touch on a little bit of the complexities about understanding, what the risk of cannabis is in mental health disorders and addictions. And then finally, I'm not going to talk a lot about this, partly because it's a short story in terms of where the evidence base is. But a lot of people will use cannabis for mental health disorders, and I think we would all predict that with the advent of legalized cannabis, there'll be people who and many people who already do. Some of that 12% are maybe self-medicating for mental health disorders. So I'm going to just touch on the evidence or lack thereof for cannabis as a treatment. So first of all, just touching on the issue of brain development, it's just important to note that adolescence is a vulnerable period for brain development. There's a lot going on. And actually, from a scientific point of view, adolescence does not end at 18. So that's actually kind of an important issue, and with regards to some of the policy decisions that have been made. And kind of in a very general sense, so this slide represents the work of particularly a group of scientists, the National Institute of Mental Health in the U.S., led by Jay Geed. There's really kind of a typical pattern of brain development that occurs in adolescence that kind of, roughly speaking, kind of goes from back to front. And what I mean by that is sort of more what we call more frontal areas of the brain. They're involved in certain aspects of higher cognition, like controlling one's impulses or regulating emotions, or things like what we call executive functioning, so planning, that sort of thing, are a little later to development. And you'll probably, many of you who have teenagers will likely see that some of those, they can be they can show remarkable cognitive abilities in many ways, but they tend not to perhaps be as good at controlling their impulses. And so that, it's relevant for 2 reasons. One is they are perhaps actually more likely to be interested in some cases in using cannabis and experimenting with other substances, but it also is relevant in that it may be that that this is a particularly vulnerable. There's so much going on. It's such a dynamic period that's an important consideration in terms of the potential impact of cannabis. So what do we know in terms of the impact? And in fact, there's a lot of unknowns in terms of the impact on brain development. There is couple of really important points that when we're looking at the impact of cannabis on brain development. One is it's sometimes difficult to tease out, what is what we call in research, what's a correlation? So 2 things happening together versus actually does X cause Y? So if we see an association between cannabis use and some aspect of brain development, is it actually cannabis or is it other things that go together with cannabis use? That's one consideration. And a second consideration is it, what's happening in terms of the cannabis use? When is it occurring? Is it occurring early or late? And how much is being used? So this is, I present this slide. This is an often quoted in the research literature study, and overall a well-done study. And what it is a study that was done in New Zealand, where it's called the Dunedin study, where they followed a group of kids from very early in life. They're no longer kids. They followed them into adulthood now over time, and they looked at a number of things, and they did have data on cannabis use, and they did over time assess these individuals for a variety of things, and one of the things they assessed was they did neurocognitive assessments at various time points. So they were able to look at IQ. And they did, in fact, identify that, and I'll briefly walk you through the slide, that there were changes, so concerning, but I'll talk about some of the caveats about that in terms of long-term impact of early and frequent cannabis use on IQ. So really what's happening here is on the on the left-hand side, we have, and I'm not sure if my pointer is showing up here, but basically we have the change in IQ. The 1, 2, 3 is basically, were they using on a regular basis, and they define that as daily or nearly daily, at 1, 2, or 3 time points. So how persistent was it? And they were, and again, I mentioned they followed these individuals, a long time. So they were, the earliest assessments were taking place at age 11, and I believe the latest assessments were at age 38. So this is a very long period of time. And what they found was that basically the real risk factor was using cannabis at a very early age. So before the age of sort of in adolescence, essentially early adolescence. In particular, they found that that was one risk factor, but also the how often they used it and how persistent it was. And this is kind of being borne out in other studies, and there are some possible moderating factors, including that again are being sort of looked at in other studies and which are still not very well understood. So things like, who is vulnerable? Could there be an underlying genetic differences? Could be boys or males versus females? Could there be a difference? Use of other drugs, etc. Interestingly, when we go down to, so that's kind of looking at assessing intelligence, basically IQ. When we look at the evidence in terms of brain imaging, the evidence is equivocal. It's not clear. So there are some studies that show changes in structure and function over time, and others don't. And again, there's lots of confounding factors. One of the major studies that showed no differences was very careful about controlling for use of other substances, in particular alcohol, and they found that if you control for that, any differences kind of go away. So it may be that there's multiple. So individuals who are using cannabis in early age are likely using other substances or abusing alcohol, etc. There is some animal work looking at mice, and these do suggest brain changes, but there's some odd inconsistencies between what regions of the brain are associated. Mice, mice are not humans, and there may be some differences there too versus in human studies. And as I mentioned, there's lots of complicating factors. So, I think there's reason for caution based on that Dunedin study, but it does suggest that very early use is important and may have a greater impact, and it suggests that persistent frequent use is a key factor. So this is not everybody using cannabis, but a particular group of individuals using cannabis. So shifting to what's the clinical impact. So who's at risk of developing, and as I'll tell you, there is a risk of developing certain mental health disorders that may be related to cannabis. Again, reason for caution. And so who is at risk? And the best evidence we have, again, repeating what I said about brain development, that there is a risk for substance use disorders, so actually having a problematic use of cannabis or becoming dependent, basically needing to use cannabis on a regular basis to obtain the same feeling and having an impact on one's functioning. And that, again, the risk of that is frequent, heavy, and early use. There is a second specific area in psychiatry where the evidence is relatively strong that there can be a risk, and that's for the development of particular kinds of disorders, what we call psychotic disorders, the best known and most severe being schizophrenia. Again, this seems to be not only related to cannabis use, but it's related to having a vulnerability. So having a family history of mental illness, presumably having a genetic vulnerability, leading some professional bodies, such as the Canadian Psychiatric Association, my professional body, to kind of really state that there should be caution around people who know they have a family history of severe mental illness. So just going, again, just briefly touching on cannabis dependence, I mentioned that the risk is largest with early and heavy and frequent use. There is, overall, we talked about the 10% that are using cannabis, and what we see is that 10% of those become dependent. And although that may sound high, it's actually lower than some substances that are already legal and already being used on a regular basis. Interestingly, I think cigarette smoking being, among probably the most addictive of sort of our widely used substances. However, that 9% goes up. There's some evidence that with use early in life, that could be 1 in 6, so 17%, and that can go up further. And these may be combined risks as well. Starting early and using regularly can increase the risk even further. But daily use increases risk as well, quite significantly. And again, just touching on this issue of cannabis and psychosis, or disorders such as schizophrenia, as I mentioned, there is that Dunedin study, the long-term study from New Zealand that I mentioned. That same study suggests increased risk of psychosis, again with early cannabis use, same theme, and that the preponderance of evidence from other studies that have looked at this specifically suggests the risk, again, is heightened by family history. There's some interesting evidence that when people have started to look, as we can now, at specific genes and genetic markers, there may be some ways of getting at that risk even more precisely by looking at particular genetic markers. This is one particularly interesting study, for example, where they identified. So these were people, and the risk of developing psychosis or psychotic disorder such as schizophrenia, and they found that the one group that was at very high risk was people who had, two things going on. They had very frequent use. They were using cannabis every day, and they had this genetic variant. Again, it's one study. It's looking at one particular genetic variant, and we have many genetic variants. Hundreds of thousands of common genetic variants, but at the same time, it was kind of an interesting and compelling idea that there may be some precise genetic risks as well. So, kind of pulling together the impact I showed you on brain development, and also thinking about the risk for mental health disorders, the Center for Addiction and Mental Health has produced some useful guidelines about lower risk cannabis use, and really taking a harm reduction approach. And I've this is sort of extracted from that. There are some other guidelines around things like driving and that sort of thing, but I've kind of focused on the risk for mental health disorders. And they're kind of guidelines that, again, I think will follow from a lot of what I said are, sort of delaying use. Don't use it young, delaying use until early adulthood, and, kind of at least at the legal age. That frequent use should be avoided, so daily or near daily use should be avoided. One thing I haven't touched on, but is sort of important in the literature, is there are more and less potent versions of cannabis, and using less potent products probably reduces the risk. And then this issue around, there may be some individuals, if you know that you're vulnerable because of a family history of schizophrenia, for example, probably best to avoid altogether. You are at particular risk. And then maybe common sense, you avoid multiple risk factors as well, may put you at even higher risk. One thing that kind of relates back to kind of the policy issues that I just wanted to mention, it is an interesting issue, is the debate around the age of onset of cannabis, and that of cannabis legalization. And that, you may or may not know this, but essentially the federal guidelines mandated that the minimum age should be, no less than 18. But each province was given the option of setting their own. The majority of provinces and territories, I'm assuming too, they actually opted to peg the legal age at where the legal age of drinking. So Alberta being an obvious example of that, so 18 for both. Whereas the one, and I guess in this case, interestingly, sort of had a distinct society about this as well. Quebec went in a different direction and set the legal age of use of cannabis at 21, whereas the legal age for alcohol is 18. So kind of an interesting difference. And I think the justification was based on this idea that there may be vulnerability still because of the brain continuing to develop and so forth. Again, this is going to be brief but I wanted to just touch on it. Is that this idea of whether cannabis may be a treatment for mental health, and the short story is that the evidence is extremely limited that it can be a treatment, and it's partly because it's very difficult to do research on cannabis, or has been prior to legalization. So I'm expecting we will see studies looking at cannabis as a treatment. But we know sort of across medicine that cannabis is primarily, the best evidence is for things like chronic pain or antiemetic use, so anti-nausea use in chemotherapy. And there's some other medical uses where there's at least moderate evidence. But in mental health, and I've kind of highlighted in red, where it's been, at least there have been trials in mental health disorders, the evidence is very limited. However, interestingly, and I borrowed this slide from Fiona, what patients are using medical cannabis for is kind of interesting. So, the largest use is for where there is good evidence in many cases, chronic pain. But interestingly, one of the bigger uses, in fact, I think it's the next greatest use of cannabis, is for mental health disorders. So depression and anxiety, where the evidence is scant at best. So again, it'll be interesting what we'll see with legalization as to whether more people will use it for medical reasons and particularly self-medicate. So yeah, so that's the end of my part of the presentation. I guess we'll open up for questions. Yeah. So thank you.
All right, great presentations and really to the point and very helpful. And now it's your turn. What's on your mind? You can share a comment, you can ask a question. Yes, so there's a question about what are the active ingredients in cannabis?
Yeah, I mean, I can take that, and feel free to. So, really, the active ingredient of cannabis is THC. So, tetrahydrocannabinol. Yeah. So it's a chemical called THC, but there's varying degrees of potency. So, in terms of the level of cannabis you have, now cannabis as a plant. It also produces a cannabidiol as well. So there's an oil that as well that can be produced from the plant. But the recreational use of cannabis is and what we call the psychoactive ingredient, the one that gives the high, is THC. And again, kind of alluding back to the earlier talk, there is varying degrees of potency of THC, and there's been a trend with newer. With the development of cannabis over time for it to be more potent. Again, that's also an issue with some of the earlier studies. We're looking at less potent versions of cannabis versus some of the newer ones.
And one thing maybe to add to that is that you might want to know how's cannabis working? Well, in our body, we have receptors in our brain tissue that receive the cannabis, the THC molecules, and have an impact on our brain. That's what causes the mood elevation and the other things. And we have an internal cannabis system. It's called the endocannabinoid system, and it's activated sometimes, for example, when we do pleasurable things or we do a lot of exercise. And some of what the cannabis is reacting to is receptors in our own body that were given to us for the purpose of feeling good. There's a question in the back.
Yeah, I volunteer with the city of Calgary. I volunteer with the city of Calgary, and I live in an apartment building where people smoke marijuana when they aren't supposed to there, because in apartment buildings they restrict it. Is there a way they can maybe, let's say, charge people fines if they're caught doing this in private or like places or apartment buildings, or especially in hospitals, doctor's office?
So that's a great question. Everybody heard it. It speaks to the policy issues of can marijuana smoke or cannabis, when it influences other people, what recourse do people have if they don't want to smell it? Oh, and is there such a thing even as secondhand smoke? So turn it to our panel.
Great. Thanks, Eddie, and thanks for the great question. So in Calgary, public consumption of all kinds is illegal, except for special exemptions that will be granted for festivals. So we're expecting things kind of like you would see at a beer garden. If you go to a summer festival, there'll be a cannabis garden. But what is legal is to smoke on your own property, inside your own home, and that would include an apartment if it is not included in your rental agreements that you should have, that it is a non-smoking property. So it will vary case by case in your specific situation. In terms of secondhand smoke, there are risks to people who are not smoking. So some of the work that we did demonstrated that for a non-smoker who is in the presence of people who are smoking in an enclosed area that has like very little air movement, so the windows are closed, for example, you can test positive or blood and urine for THC as the person who is not smoking. So there is a risk to yourself. And that's particularly concerning for people who might have safety-sensitive types of jobs where you might be exposed to kind of random drug testing, and you could test positive for THC from just kind of being in the kitchen party with someone else who is smoking. So definitely something for you to think about. The kind of exposure where you're walking through the park and there's someone sitting on the grass smoking, that the ventilation is too high there for you to be able to absorb the THC. So that kind of situation is not worrying. It's really about the enclosed space and the amount of smoke that you might be inhaling into your own system.
Great answer. Yes, over here.
Yeah, you gave an explanation of the THC component, and that's what I think the majority of focus is, but isn't there a large medical application relative to CBD?
Yeah, no, it's a good question. I mean, some of the use of and some of the use of CBD for medical reasons, has focused on things like anxiety, depression as well. So the studies that I popped up were mostly on cannabis as a use, but some of them are done on CBD. And again, at least in my area, and Eddie, you maybe can comment if there's other medical uses of CBD. Again, the evidence is pretty limited for CBD as a treatment for again like in my for mental health specifically. So people will use it for anxiety or anxiety, depression, that kind of thing. But it's not clear that it's effective, and it may be. The studies have been, again, there are not very many of them. They haven't enrolled enough individuals, that sort of thing. There may be some limitations to the study. So, so that is one of the medical indications as well.
So just to clarify, CBD is cannabidiol, which is
Yes.
the other component of cannabis in addition to THC. It's the more prominent one used in medical marijuana and used for medicinal purposes. And it seems to kind of counterbalance the high or the active brain activation that can occur with THC. It limits the paranoia that sometimes people experience with THC. So just a couple of things that I can share with you from what we see in the emergency department and in some other work that I'm involved with. So I'm working with a group. Sickle cell disease is a very painful condition that people of African origin can get that affects their bones, and they get very, very painful crises, and they suffer from chronic pain. And I'm working with a guideline group in the United States to see what would be the best way to treat them. And we've reviewed the research across all of the studies that have been done, which asks the question, is cannabis effective, or cannabinoid treatments effective for chronic pain that is not related to cancer? And the studies show it doesn't really help. There's no improvement in pain scores. But on the flip side, I'll tell you what I'm seeing in the emergency department, which is lots and lots of patients who are convinced and who are taking medical cannabis because they feel it's helping their pain. So the studies are not showing that the pain scores are moving, and that's how these studies are conducted. Their chronic pain is always stuck at 7 out of 10, and cannabis isn't helping any more than a placebo. But people are feeling better. They're functioning better, and that's obviously, it seems, why they're staying on it and why they're taking medical marijuana.
Yeah, I would agree.
Yes. I'm going to bring you the microphone.
I'm an RN. I'm here from Olds, and it's a rural hospital. I work maternity on the active inpatient unit as well as the ER department. And we get people who admit to using marijuana on a regular or frequent basis. And what we are finding anecdotally, and I haven't been able to find any evidence why, these people seem to have a low pain threshold. They get in a car accident and they hurt horribly compared to somebody in a seemingly equivalent situation is sore. And it takes more opioids to treat the pain that they are perceiving. In the same way, these people go for anesthetic to have a procedure and they should be discharging at the end of the day from a day procedure. They're getting admitted to our inpatient unit because it took so much anesthetic to anesthetize them. They're having a hard time waking up and we need to monitor them for their oxygen saturation. Why, how is this interaction between pain threshold and cannabinoids and opiates?
I can take a first crack at that. And what I can say is that it's not, I can't answer that question, but I can tell you that cannabis has another very paradoxical effect. So we heard from our presenters that cannabis is a treatment for nausea and vomiting. And cancer patients who were taking medications, chemotherapies that made them nauseous and vomit would experience relief from cannabis. But as you also know, regular cannabis users can experience a not uncommon complication called cyclical vomiting. Some other people call it cannabis hyperemesis syndrome. And this is a crazy condition. We see this now regularly in the emergency department, and people come in unable to stop vomiting. The cannabis is making them vomit, even though it's supposed to be used against vomiting, and they're vomiting multiple times an hour, very deep vomiting, like a very noisy vomiting. We can sometimes make the diagnosis just by walking in the room. Because if we hear from cubicle 5, I don't mean to make that but we say, oh, there must be a cyclical vomiting patient in that cubicle. There is one other really crazy thing about this cyclical vomiting. Patients treat themselves at home with hot showers, and that relieves their symptoms. And I don't think we have a great explanation or understanding, but it shows that cannabis, whether it be the THC or the CBD, has paradoxical effects both for pain, as you've pointed out, and both for nausea and vomiting.
Yeah, I don't have anything much to add other than, we were talking about what makes up cannabis, and you were pointing out about the internal cannabinoid receptors that we all have. Just that, like many receptors in the brain, they're also spread throughout the gut. So there are, marked effects on the gut, and there's some of our researchers here are actually very interested in that area of the impact on the gut and its potential medical uses, but also its potential medical impact as well.
Yes, we'll come back here.
I have two questions, one for yourself. We know how our emergency rooms are all overburdened right now, and I'm sort of hearing from you that you're seeing a lot of people coming in with cannabis problems. So how are we going to handle that increased load? We know that on a Friday evening, Saturday evening, all the alcoholics roll in. Are we going to see the same thing with the cannabis users? My second question is, having never used the stuff, is 30 grams good for one evening or a week or a month?
So I could take the first question. It's a really great question. I'll leave the 30 grams to you guys. Yeah. But No, there's no doubt we are seeing the cannabis hyperemesis syndrome. We are seeing young people or first-time users having bad reactions. And Dr. Arnold referred to psychosis. They come to the emergency department in a panic. They feel they're being chased. They're paranoid. They're unsafe to go home because they feel that people are after them. So we have to keep them in the hospital, and that's a burden. What I can say is two things. Number one is I've spoken to and heard from our colleagues in Colorado, which is one of the states that have legalized, and they did see a small increase in emergency department visits after legalization. There was more use, but it seemed to settle after about a year or two, and it went back to where it was before. The other thing I would say is that in comparison to what we see as the ravages of alcohol, cannabis is a drop in the bucket. So when I come home from a busy evening shift in the emergency department, I see people who've been in car accidents because of drinking. I see violence because of drinking. I see youth that have become poisoned because they've drunk too much. I see people whose livers are destroyed from years of drinking. I see people who have to be hospitalized because they stopped drinking and now they're in withdrawal. And I have shifts where if there was no alcohol, there would be no patients. And that is a hugely greater a problem than anything that I think we see with cannabis or that we will see with cannabis.
I'll comment on the 30 grams. So that's a lot. It's like a sandwich bag. So for most people, if you were smoking a joint a day, that would do you for an entire month. So.
Yes, there's a question over here.
Thank you. You've spoken so much about what we know and what we don't know in the research, and that's what I hear from the media too. Can you think of another example in the past, besides marijuana, that faced a similar sort of lack of, before it was exposed to this great social and now your president's medical experiment?
Mm-hmm. Well, I guess I would say there are many things that we have that we don't understand as well as we perhaps should. And so, I mean, to Eddie's point about alcohol, that's very socially pervasive. I think about 80% of Canadians report drinking over the last month. It's very socially accepted. And there are many, many effects that we do not understand and have not well documented. Similar with many prescription drugs, there are many treatment options and different interventions that we do that are perhaps more art of medicine than science of medicine. So I think there are lots of other things that we don't understand and are very prevalent in our society. Paul, do you want to weigh in?
I mean, the only thing I'd add, and this is venturing a little bit into your area because I think it's more about policy, but I'm sort of thinking of the example of alcohol that, you know, has been socially accepted for so long. Oh, I'm sorry. So, you know, thinking of the example of alcohol that's been accepted socially for so long, it took a very long time for society to create regulations around drinking and driving and kind of being, whereas I think based on the lessons, partly based on the lessons from alcohol, that's been very, very much part of the conversation from day one with cannabis legalization. You know, what are the guidelines? It's still, I mean, there's a lot of difficulties in terms of, you know, it's not without its challenges, but at least that's something that's being thought of right from the get-go, that you can't, you know, drive and use cannabis, whereas, you know, it took a long time for us to get there with alcohol.
So great comments, and I think the situation is maybe a little different here because we're looking at data that tells us that there's already quite a bit of use. So to regulate it and to make sure that it's controlled is maybe one of the advantages.
You mentioned the seniors were the fastest growing group. What's up with that?
There are probably others in the room who could answer better than I could. But I'll share my hypothesis with you. So I think there's probably two things going on. I think in general there is a kind of developing pop culture idea that it is good for what ails you, and so little aches and pains. I think there is probably a certain segment of that market that's trying to self-medicate and having some success with that from the anecdotal evidence I've seen. I also think that there's just, I tried this back in the day, and I'd like to come back to it and try it again. My son's doing it in the backyard. I'm going to join him today. Those are my two hypotheses. Paul, do you have any insight that?
Great. Yes.
No,
Yeah.
If you were on medical marijuana, would a doctor be able to give you advice on how much, when, all that type of thing? Or is it just you get this medical marijuana permission, and what happens from there?
Yeah. I mean, I think there will still be, marijuana that's prescribed, and in which case it's like any other drug where it's, here's how much you should take and how often you should take it. I guess what's going to change is that some people now will, because it's available legally, some people will choose to use on their own and self-medicate kind of thing. So just like some other substances that are available over the counter kind of thing that'll be available to them to use as they wish. I don't know if you have any other comments.
Yeah, no, I mean, if you've driven through our city and through BC, you'll see many dispensaries.
Mm-hmm.
These are legal stores that cater to the filling of medical marijuana prescriptions. So they are technically under medical supervision.
And I think she probably has a better answer from experience at the end.
I just have a question. I'm not at all familiar with cannabis. I don't intend to be. But I just wanted to know, if I were going to go buy some, is there different kinds of marijuana, and the people that are dispensing it and opening these shops, how knowledgeable are they to give you advice on whether you should have A, B, C, D, E marijuana?
That's a fantastic question, and it speaks to the difference between smoked and edibles. I don't know if Fiona, you want to take that?
Yeah, so definitely there are lots of different products that are coming out onto the market. And the good thing about a legal supply is that it has to be clearly labeled what the THC content is. And the higher that content is, the more psychoactive properties the product will have. And it also has to indicate the CBD level, so the cannabidiol that we've been speaking about. So depending on how comfortable you are with cannabis use, the general recommendation is start low and go slow. So start with a very low THC product, and if you wish to increase in frequency or THC content, move forward very slowly and kind of wait and see how your body reacts before you try something more potent or something more frequently. So that's the general advice. Speaking in a broad generalization, my experience with people who own cannabis shops is that they do have a lot of experience with the different products that they're carrying, and they are, at least in the medical realm, very deliberate about what they are bringing in and what they are offering to their clients. So you're seeing a very interesting kind of like discerning consumer emerge here, and the industry is responding by genetically modifying different strains to achieve different mixtures of THC and cannabidiol. So I think you can expect your experience, if you're going into a shop, to be like pretty high class. They're very, the ones I've been in are like, they're very classily decorated and, very chic, I would say, is the word perhaps I would use. So yeah, there definitely is a very sophisticated market that's emerging.
Where are these people educated to learn this, to give it to the public?
Well,
How do you know work? I've never heard of a course being given or anything like that.
there are courses that are emerging very recent. There's a course at Olds College around cannabis horticulture. There's a course around business management for cannabis. So it's definitely an emerging market, and it's being, the voids that are recognized in terms of skilling up the trades are being recognized by our institutions and filled very rapidly.
Paul, anything to add?
No, nothing to add.
And just one note of caution. The cannabis that's consumed via smoking or vaping is going to be absorbed to the brain much more quickly, and the effects are within minutes. If for people who are going to, as following up to your question, if you're going to go more with something that you eat, the effect is quite delayed, and people often make the mistake of, well, that didn't work, I should take more, and then when it all kicks in, they've taken too much.
And Eddie, I'll just add on to that point. So up until now, actually in the medical framework, edibles have been legal. As of tomorrow, edibles are illegal in both the medical and the recreational market. So you are welcome to make your own edible products, but you cannot buy or sell them. Edibles will not be online until next year.
Hi, I just have a comment about retail cannabis, that is the non-medical side. My understanding is that the retail stores that are opening here in Alberta starting tomorrow are not allowed to give medical advice. So if you get in there with a desire to treat a particular illness, those retailers should not be giving you advice as to how you treat an illness. They're there to dispense cannabis. They can tell you what the different strains are, what the level of THC, what the mix of CBD THC is, those sorts of things. But my understanding is they shouldn't be giving any medical advice on how to treat an illness.
Thank you. Great comment. Yes, you haven't had a chance yet.
I have two different questions. So one is I had heard on the radio this week, it was a Government of Alberta ad, saying that if you smoke cannabis, you should not be smoking cigarettes right after because it does something, alters something in your body that it makes the smoke more harmful. Is that correct?
Yeah, sorry, could you repeat that?
Basically, that there was an advice given from a government ad that smoking cigarettes immediately after cannabis could be problematic or could have some adverse effects.
Yeah, not that I'm aware of, but
yeah,
yeah.
Me neither.
I don't know if Eddie. Oh, interesting. Okay, yeah.
And then the other thing was, okay, so there's all these different ways of taking in cannabis. So is like vaping less dangerous to your lungs than smoking?
Vaping or smoking, which is less dangerous?
Yeah, I think they would be similar from the kind of my department kind of thing up here with the brain, it's kind of sort of in a psychoactive sense. In terms of its respiratory effects, again, Eddie, you could comment, but my assumption is that vaping would be safer, but you could perhaps comment.
So the reason we get lung cancer from smoking is because of the tar and the nicotine and the fiery smoke that is released when we burn tobacco leaves, which would also be to some degree burnt when we burn marijuana leaves. So it's not, I don't think it's a big difference, but technically vaping would be safer as long as it's a device that's not going to set your house on fire.
Yeah.
Hi, I was just wondering, you said that some kids have alcohol poisoning when they come in, they take too much. Can you do the same with cannabis?
Great question. Is there such a thing as a cannabis overdose?
Yeah, yes. Yeah, absolutely. Yeah, so too high quantity can increase risk for some of the acute. I talked a lot about more of the chronic psychoactive effects like risk for mental health disorders. But as Eddie alluded to, people who use too much cannabis can become paranoid, can have acute psychoactive effects, incredibly anxious, have panic attacks. So that can certainly happen with excessive consumption. So yes, essentially you can certainly have risk of elevated cannabis use and effectively a cannabis overdose. I don't know if you could comment from a medical point of view what the impact would be as well.
Yeah, yes, rabbis.
I was going to say, I don't believe you can die from an overdose of cannabis, though.
It's exceptionally rare. There may be some kids who have succumbed to that, but unlike alcohol and fentanyl and opioids, when in the overdose situation you'll actually stop breathing and die, you would not have that same effect of an overdose of cannabis. You would get those bad reactions, but they wouldn't be fatal like an alcohol poisoning could be. We always hear about the university campuses where unfortunately a couple of kids die every year from alcohol poisoning.
One question before I go. in a rush. I wanted to ask, does marijuana contain gluten? Are people with celiac disease able to have?
Any celiac issues with marijuana that are not in an edible?
Yeah, not to my knowledge. I don't know, Eddie, if you're aware of anything, but yeah.
Oh, yes.
This is a policy question. I'm wondering where Alberta law enforcement is with testing for impaired driving.
That's a very underdeveloped area right now. So there is no reliable roadside test for impairment. The way to test for THC is through a blood or a urine sample, which of course the police could not take at the roadside and analyze. So at the moment we will be relying on subjective measures of impairment. So just as we do now, if you are behaving erratically or driving dangerously and the police have cause to pull you over and suspect that you are impaired, they will take you out of your vehicle and get you to stop driving. So it will be the same as it is right now for enforcing impaired driving until some kind of roadside test is available.
Would you go over that again about driving?
So at the moment, we don't have a reliable roadside test. So the way that the police would be approaching it is the way that they're approaching it now, which is subjective measures of impairment. So if you are driving in a manner that is dangerous or unpredictable or appears that you are driving like someone who would be impaired, they can pull you over. They can administer further subjective tests, so things like asking you to walk in a line, reciting the alphabet backwards, things like that. And then they can get you to stop driving right then and there. So until there is something reliable that they can do on the roadside, we're going to be stuck with these subjective measures.
Yes, in my line of work, if I were to paint it in sort of simplistic terms, so I work as a psychologist, and if it used to be that mom brought Johnny or Jane to get treated for anxiety, it's almost like flipped right now. So now Johnny or Jane would give gummies to treat mom when she has anxiety. And so I know that you had alluded to scant evidence when it comes to the link between cannabis and anxiety disorders. We know that anxiety disorders are quadrupling over campuses and probably amongst the middle age to older. How do you explain, other than saying there's a scant or weak evidence, how do you explain the connection or the lack of support between cannabis and anxiety?
Yeah, I mean, I'll kind of sort of comment on one part of what you're saying, then go back to cannabis. But I mean, I think, you know, and again, I think it's a broader topic around the evidence that there may be an increase in anxiety, certainly anxiety symptoms, if not anxiety disorders, and particularly in younger people. And there are a variety of proposed explanations for that. We don't really know. It's, again, it goes back to that issue of, you know, correlation versus what causes. People have, you know, talked about the potential for the, you know, use of social media, that sort of thing, and losing some social connections that could help counteract. People have talked about a period of rapid social change where people feel, you know, the level of stress, psychosocial stress has increased, and that's increasing the level of anxiety. We don't really know, but there does seem to be. It's certainly an increase, again, in anxiety symptoms when people have done studies where they've done measures of anxiety. The issue around cannabis is somewhat a separate one, in that, you know, there have been a limited number of studies where people have And some of them have used, we were talking about, THC versus cannabidiol. Some people have used the CBD and for treatment of anxiety, for things like social anxiety, for example, one of the larger studies that was done. And the evidence just isn't clear at all. And it may be that, again, we just haven't done enough research, and partly because some of the barriers of using cannabis before it's become legal, or it may be because it's not helpful for anxiety disorders. We don't really know. So that's kind of more what I meant. It's like a lack of evidence rather than ruling it out. And there certainly are people who will self-medicate and say that CBD, for example, is helpful, but we don't have evidence that it is based on trials. Yeah, I mean, the hypothesis and people have tried it is that, as Dr. Lang was mentioning, that we have these internal cannabinoid receptors. They interact with parts of the brain that are involved in regulation of emotions and anxiety. And the thought is that maybe by influencing those receptors, we might be able to reduce anxiety, just as influencing. We know, or we do have evidence of some medications that we know work. Again, they act on other neurotransmitters that seems to have an impact on anxiety and mood disorders and things like that. So the assumption is it may work for cannabis, but we just don't have the evidence again. But they're harder to study, again, because of the legal barriers that we've had in the past.
So we do have some snacks for you over on the other side. Maybe no brownies. And I think we just have time for one last question before we call it a night.
All the information we're receiving relative to hospital visits, emergency visits, etc., is based on the fact that marijuana is already embedded within our society, and the usage of that product is primarily from the black market, which is uncontrolled. So, two questions. There is an embedded percentage. I think it was 10, 11% you're saying now. What is the expectation of increase in that percentage, number one? And number two, is there an expectation, a positive expectation that the control of product, the government control of product, will have a positive effect through the legalization?
Yeah, so definitely one of the goals of legalization is to eliminate or at least shrink the black market that currently exists. And the way that the government is doing that is by hopefully offering a stable, more accessible, safe, cheaper supply than the black market. So they just released the pricing structure yesterday, and it is 25 cents per gram cheaper than what you might think for the black market, depending on your dealer. But so they're just undercutting it. But that safetiness and the fact that it's going to be more convenient, possibly, the expectation is that the people who are purchasing from the illegal market will over time shift to the legal market. And similar to you might see with alcohol, where it took time, but there's a very, very small, if any, black market for alcohol now, because it's just so prevalent and so accessible within society. So that is definitely one of the goals. We are not expecting to see a big spike in use. As Eddie said, the experience of Colorado was that there was a little bit of a bump and then rates returned back down to normal. The other states that legalized didn't even experience that initial bump. They had just steady rates of use as they did pre-legalization. So we are not expecting our experience to be any different. Really the big gain will be shifting the people who are using into the legal market.
Very sound.
Is cannabis a sleep aid?
That's the very last question.
I mean, there have been studies where it's been used as a sleep aid in specific conditions. I mean, there's been studies as generally as a sleep aid, and but I think for example for MS, so people, in other words, people have other conditions where cannabis may be effective and may also, as an outcome, improve their sleep, chronic pain as well, but as a generic sleep aid for people who have sort of primary insomnia that's not related to one of the other conditions, we don't have the evidence that it's helpful in that regard.
So on the eve of legalization, I think we were very, very fortunate to have been joined by two extremely knowledgeable panelists. Join me in thanking them. Thanks as well to Jennifer Hatfield and the Cummings School of Medicine for supporting this event, and for the rabbi who opened so generously the doors of the synagogue to have such a great discussion tonight. Thank you for your attendance and for all your great questions. And we'll see you hopefully at the next Tzed Talk.